Welcome back to another mini podcast in our special series on cancer care during the COVID-19 crisis. The pandemic continues to present new challenges to oncology care delivery. We're here to give you quick tools you can use right now. Today, developing a testing plan for your cancer center. With us today is Dr. Zoe Larned. She's the chair of the Hematology and Medical Oncology Department at Ochsner Cancer Center in New Orleans. Can you describe for us your testing strategy and when you developed that in the pandemic?
Yeah, absolutely. So we, as you know, in New Orleans and the Louisiana regions were a hotspot pretty quickly. We had our first confirmed COVID-19 case in New Orleans on March 9th, so we had to work on responding pretty quickly. By March 13th, we already had our screening processes implemented and our inpatient hematology oncology protocols developed, and all inpatients were tested for COVID and cleared. And then obviously anyone coming through the emergency room or for inpatient chemotherapy was also cleared. By that following Monday, March the 16th, we had already initiated telemedicine visits, and we were very quick to ramp those up to the point that we actually saw 80% of our patients in this manner. In between March 9th and May 30th, we saw over 10,500 patients this way. So obviously that was one way to protect our patients from exposure as well. The system as a whole began their first testing on March the 20th to keep all of our inpatient units free, but also to keep our infusion bays free. And then throughout the month of March and early April, our testing capacity changed as we had access to more testing kits. We, on April 7th, actually made a decision to move our entire inpatient unit to another campus for sterility. And on April 9th, we had all of our chemotherapy infusion and radiation oncology testing protocols developed and ready to go live for the system. Now, each location was a little different in when they could get the testing unveiled based on their supplies and getting the patients taught on what the new procedures would be. But we had everything kind of going for the majority of our patients starting in early April as a result.
So I understand your strategy evolves around a certain number of points, and I'm assuming that evolved over time, right? The more that you learned. Could you explain those points to us?
In the beginning, we were certainly much more aggressive. There were several reasons for that. One is to keep the outpatient infusion areas clean of COVID as best we could. That was obviously for the protection of our patients that were susceptible because of immune susceptibility, but also our staff as comfortable as they could be through this entire process. So the beginning strategy really involved every patient coming for infusion starts required COVID testing within 72 hours. That was to accommodate for the weekend as well before they could proceed with the therapy. And then based on their test result, it depended on what part occurred next in the protocol. So for example, if they were negative, they clearly went on with their treatment infusions. If they were positive, then the next strategy was based on really CDC and ASCO guidelines. And we managed symptoms very carefully. Initially, we didn't retreat anyone for 2 weeks, and then we did repeat the test to confirm negativity. Obviously, we learned along the way that there were some patients that maintained a prolonged positivity. And as we learned more about that, we started making decisions based on symptom management and time from the first positive test. Really, the only patient population that we still remain very aggressive with testing for every chemotherapy cycle now is our acute leukemia population and our high-grade lymphoma population. The other populations we test for first new treatment start and then don't test again unless symptoms mandate at this point.
What's a key piece of advice that you like to offer cancer programs when developing a program-wide testing strategy?
I think the first point is, there are a lot of unknowns. So especially when we started this process, we're basing decisions on what we felt most comfortable with to protect our patients and protect our team, knowing that at that point, there wasn't going to be a lot of guidance scientifically to tell you whether this completely worked or did not work. But if you were open and honest about the dialogue and the rationale for why, we found that both the patients and our physician and provider team bought in very easily to this. The next thing that we were really transparent about it. We discussed what it would involve. We helped set up facilities, including drive-thru testing and home testing capabilities to get this launched and off the ground quickly. We recognize that different infusion rooms had different needs in terms of being able to socially distance and how they had to get their tests done. And we adapted to the models that these centers needed. And then we were, transparent enough to discuss that we would also evolve the process as we learned more information scientifically or learned more from our patient population as well. I guess I would also comment, there had been a lot of concern about patients' buy-in because certainly it's a swab test. And I have to say that the patients were actually extremely satisfied with the approach. They also wanted to know that they were safe to get their chemotherapy and that they would be safe when they were in an infusion area surrounded by other patients, for example. We actually got very few complaints, and really all of those came through me to assist in management. So it was rare that we had a problem with a patient that was uncomfortable doing it. We were also cognizant of the fact that there are some unique patient populations, head and neck cancer patients, for example, or patients with significant cytopenias, specifically thrombocytopenia, that we had to be really careful with. And sometimes we manage them a little differently than we did others on this protocol.
For more on testing approaches and resources you can use, check out the show notes for this episode. Next week on Cancer Buzz, we'll talk about how your program can build staff resiliency during this stressful time. Until then, for the Cancer Buzz team, I'm Summer Johnson. Stay well.